So thank you for being here today with us. This presentation is on epidemiology for health. This project team has been tasked with conducting a desk review of national and subnational health statistics, demographic health surveys, recently conducted medical and public health research. And what they're going to do is come to some conclusions about the health status of the patients that FIBUSPAM serves in Ecuador and the demand for certain services and potential areas for FIBUSPAM to move into. We've also conducted a one-off analysis on some COVID data that we've been able to put together. So I'd also like to thank very much our Dr. Rachel Hanisch for her presentation earlier in this process. These students over a little over a 7-week period have jumped right into this theme, and it's very inspiring, and I'm very much looking forward to this presentation. And so yeah, thank you to Dr. Rachel and to several members of our PACH team that have supported our project team, as well as Dr. Carlos and David Wacho and the team at FIBUSPAM for their collaborations over this period. Now I'd like to introduce the team. Pooja, we'll start with you. You're at the top of my screen and you can pick the next person after you.
Hi, my name is Pooja Tiwari, and I'm going into my second year of my Master of Public Health program at the University of Texas at El Paso. And I did this internship because I'm really interested in international health, and this is my first experience with global public health in Latin America. So next up is Adrian for me.
Hi, my name is Adrian Chang. I'm a rising junior at Princeton University studying molecular biology and global health. And I chose to partake in this internship because I wanted to learn more about sustainable healthcare models and how we go about providing services with limited resources and building up healthcare programs in different countries. And then next for me would be Charlotte.
Hi everyone, I'm Charlotte Kudish. I'm going to be a rising sophomore at Princeton University, studying biology and musical theater. And I joined this internship because I haven't had much exposure to global health before, and I'm still trying to figure out what exactly I want to do with my life. And this interests me greatly. And next for me is Cody.
Hi, my name is Cody. I'm a rising junior at Princeton University studying molecular biology, global health, and Latin American studies. I had previously worked in a Latin American country in public health before, but I thought this would be another great opportunity to get into Latin America again. And it's going to be especially helpful because it works in a different country and for a different target population. And so I just wanted to use this opportunity to help expand my interests and to learn more about them in terms of health and Latin America. Last is Lawrence.
Hi, my name is Lawrence, and I'm also a rising junior at Princeton University. I'm majoring in ecology and evolutionary biology on the pre-medical track. And like Cody, I also have interest in Latin America as I'm currently pursuing a minor in Spanish. And I decided to take on this internship because it was an exciting opportunity to explore my interests both in Ecuador and in the health field.
Thank you, everybody. And so I have enabled sharing, so you guys can get going with the presentation.
Can everyone see that?
Looks great.
Okay. Great. So good afternoon, everyone. My name is Pooja Tiwari, and my team of the Epidemiology for Health team, which consisted of Adrian, Lawrence, and Cody, we worked to conduct a desk review about the current health status of the Ecuadorian population. Also, Charlotte is here today, and at the conclusion of our desk review presentation, she will go in and review the community survey results that she summarized and announced, but that will be towards the end. So now with our desk review, since the current health status of the Ecuadorian population is pretty big, we narrowed our desk review down to 5 key areas. So these are COVID-19, STDs, STIs, endemic diseases, mental health, and cervical cancer. Now, to start with COVID-19, the pandemic has devastated many communities and countries worldwide, Ecuador is no exception. There exist disparities in both COVID-19 testing and vaccination, and the same groups are consistently marginalized when attempting to access both services. In order to improve COVID-19 testing and vaccine equity, communicating and partnering with local communities is the best way to work toward making these services more accessible as the pandemic continues to unfold. The first confirmed case of COVID-19 in Ecuador was on February 29, 2020, for the subsequent crisis that ensured there were many drivers. One was the lack of sufficient collection of the dead bodies, both on the street and in individual homes. These dead bodies that were not picked up contributed to an increase in transmission of COVID-19 for not only the families, but also for the medical and forensic personnel tasked with collection. Another driver to this crisis was that the medical personnel and frontline workers did not have sufficient and an active screening place at the earlier stages to monitor infected Ecuadorians, and they didn't have sufficient PPE either. Next up.
So in terms of the geographical extent of the affected areas due to COVID, in Ecuador, the case and mortality rates really varied based on the province and the geography. So during the onset, the coastal regions were found to have higher attack rates than the highlands or the Andean region. And this is due to the fact that the coastal region has a very different culture that's more outdoors, less traditional, and this leads to a higher rate of transmission because of the warmer climate as well. And people would be outdoors more, hanging out or visiting family members. However, what was found was that living above 2,500 meters was also associated with a lower risk of mortality at the beginning, but the provinces with the higher mortality rates are Andean, Chimborazo being one of them. And more recently, statistics have shown that the Andean region actually contains the highest number of confirmed cases now. And this is mainly owing to the large metropolises of Quito and Cuenca. And the number of people affected as of recent in late July, based on government reports from the Ministry of Health, there are a total of 480,720 confirmed cases from testing since February 2020, and 21,446 confirmed deaths, along with 9,351 suspected deaths from COVID due to comorbidities and the sort. So the probable total is actually around 30 and 31,000 deaths in total. Given that the case fatality rate was significantly higher for the indigenous population at 9% compared to that for the mestizos, and this can be attributed to a decreased accessibility to healthcare and various other socioeconomic factors of this population. Also, there's been shown to be a significant correlation between blue-collar work and a higher mortality rate, which we will see. And the indigenous population is more likely to be susceptible to COVID-19 and contracting it at much higher rates than the general public, as recent research has shown. So in the next slide, here we see a graph that shows various occupations and relative risk. Of exposure to COVID and also mortality, as was researched in this study. And the highest we can see is for inmates, those that are retired or the elderly, unemployed, and also blue collar workers. Whereas on the other end of the spectrum, those with a relative risk less than 1 would be politicians, nurses, surprisingly, certain health workers, and doctors. Moving on, this is another chart that also emphasizes the rates of transmission amongst different occupations. And we can see that the values are very significant for the blue collar workers, the prisoners, the unemployed, and the retired. So in summary, COVID-19 impacted various populations and various communities very differently in Ecuador, depending on geography.
So with the indigenous population in Ecuador, they've been hit hard by COVID-19 as well, but they still have work to integrate the modern practices of preventing COVID-19 as suggested by public health professionals with their traditional practices in order to prevent propagation of the virus. Additionally, since selling at marketplaces is the sole income for a significant portion of the indigenous population, they have worked to safely collect eucalyptus leaves, Santa Maria leaves, Marco and other medicinal plants, potatoes, vegetables, products that they sent to Guayaquil, Machala, and Riobamba to support their families. So the indigenous population adapted the medical and traditional practices of their environment in order to create a safe and sustainable agricultural community market to support themselves.
As for the response to date and how the government has responded in terms of testing facilities were very inadequately primed at the beginning of this pandemic to respond to the very high demand that the population expressed. And due to this, the inadequate testing capability was highlighted by this excess death rate. So a very high excess death rate which is basically defined as a very large percentage of deaths compared to the number of cases. Because testing was not available, there were a lot more deaths than could be attributed to those who were quote unquote infected or tested to be so. And as of recently, July of this year, Ecuador has expanded its testing capabilities by converting existing facilities such as schools or public community centers into testing sites. However, significant areas still lack PCR processing, a total of 7 provinces, most of them being within the Andean region. And this is problematic because although you can test as many patients as you can by expanding testing facilities, processing facilities are important for diagnosis and confirmation of a positive or negative result of COVID-19. And this lack of processing is responsible for delays and backlogs in testing and hindrances to contact tracing. Even though access is no longer as limited as before, this still remains a very significant problem.
Now, when it comes to the vaccine rollout in Ecuador, the infrastructure for rollout procedures has been poor. There existed a lack of transparency between the government and the general public about the vaccine rollout. Also, insufficient vaccine supply, specifically of the second dose for frontline workers at the beginning of the rollout, led to many problems. Also, the specific conditions of the Pfizer vaccine to be stored at -70°C made it harder to distribute the vaccine in many areas where this storage doesn't exist. With the Sinovac vaccine only needing 2 to 8 degrees Celsius storage, the outlook is looking better for reaching more rural communities where the scientific grade of the Pfizer vaccine storage is not needed.
And in terms of access to goods and services, this is related to the previous slide. For testing, in the beginning, Ecuador did not produce testing supplies and equipment necessary in country, so most of these supplies were imported or donated by international organizations or first world countries. So testing was very expensive and limited to the symptomatic, those in contact with confirmed positive cases, or those that were selected by chance as part of a government surveillance program. And this shows that as of now, further improvements in testing capacity would really help combat the inequalities that exist between provinces that have laboratories and those that do not, because the current model for testing in Ecuador and processing tests is a very centralized model where certain provinces have these processing facilities for PCR and certain ones do not. So nearby provinces would send their tests over to the provinces that do have these facilities so that those tests and diagnoses could be performed.
Now, when it comes to back to COVID-19 vaccination, the perception of whether people would get the COVID-19 vaccine has changed over time. There was a study conducted in August 2020 that found that 97.4% of the Ecuadorian population would accept a COVID-19 vaccine. However, another study conducted in April 2021 in the Azuay province, which is another Andean province looked at the COVID-19 perception in this population, and only 58% of the participants believe that a COVID-19 infection can be prevented by a vaccine, and only 46% believed that there is currently an effective COVID-19 vaccine. Also, during June 2021, Mr. David Guacho shared with us in one of our sessions that at that moment that around 40% of the Ecuadorian population is currently hesitant toward getting a COVID-19 vaccine. So what could account for why it seems as though the COVID-19 vaccine acceptability has gone down as the months progress is that, so starting with Ecuador's vaccination campaign on January 20th, 2021, it started with the Pfizer vaccine. But since then, there have been many obstacles, which included that with the distribution of the vaccines, they have not only been affected by political corruption, but also there's no clear allocation of the vaccines for the general population, like there are tier statuses here in the United States for who should get the vaccine first. Also, as of July 22nd, Ecuador only has 11.1% of their population fully vaccinated against COVID-19, as compared to the 48.7% of the fully vaccinated US population.
And in terms of the excluded groups, to bounce off of what Pujo just mentioned, there are some quotes from the studies by Ceballos Valdivieso et al. That show that the real impact of the pandemic was much worse than indicated by reports because of this coverage gap due to the inadequate testing infrastructure and possible manipulation of statistical data by the government. So given that, it is very safe to assume that there is underreporting from governmental organizations, especially from the statistics portrayed by the Ministry of Health. And the need for help is greater than it seems from the numbers.
And as for coverage gaps, so according to the Confederación de Nacionalidades Indígenas del Ecuador on their press release on their website, this indigenous group criticized the Ecuadorian government for having insufficient COVID-19 tests. Also, they claim that diagnosed patients with COVID-19 are not followed up in their communities, and there does not exist epidemiological measures either for their community. Health centers do not have essential supplies, and the medical personnel due to budget cuts are significantly less, which has left the health system in shambles.
So for a call to action for PACH or FIBUSPAM that we brainstormed is to primarily address these inequalities between provinces and between certain populations, indigenous versus mestizo, by assisting and addressing the weakest links, which are the excluded groups, the neglected provinces or peoples, through providing coverage of these COVID-19 services, because basically a country is only as strong as its weakest link. And by addressing the excluded groups that lack coverage, bringing them up on par to the rest of the population would serve to enhance the work of Ecuador as a whole in combating this pandemic.
And so one specific task that we brainstormed for PACH and FIBUSPAM that they could undertake in order to increase coverage and accessibility for COVID-19 vaccination is potentially organizing caravans in order to bring rural community members to government designated COVID-19 vaccination sites. This would ensure that individuals who live in areas with no access to healthcare services could still receive the COVID-19 vaccine to not only protect themselves, but also their community.
Okay, so now I will be presenting on the sexually transmitted diseases or infections in Ecuador. So STDs and STIs are, of course, a worldwide health issue. They are also an issue in Ecuador, but unfortunately, they are very much underreported and understudied. There's not much research has been done on STDs and STIs. The research that has been done has been focused largely on large urban populations, such as Quito and Guayaquil, which are definitely not representative of the entire country. And the numbers that have been reported are also most likely unrepresentative of the actual number of cases. And so the main drivers of these issues can include a lack of sexual health education, or refusal to use protective measures such as condoms, insufficient testing, inaccurate testing, and just general barriers, financial barriers, social barriers to seeking, accessing, and continuing treatment as recommended. And so, of course, we assume that these also will disproportionately affect individuals with less education and low socioeconomic status. Therefore, it applies, we attribute this to apply to rural communities and indigenous communities. And so there are no geographical limits to the transmission of STIs. However, the official data shows highest incidences in the provinces of Guayas and Pichincha, which, as I mentioned earlier, is most likely because they are the largest cities and have the most data available. So these are some numbers: reported HIV status from the Guayas province and the Pichincha province, and then also from the Chimborazo province for reference. There are similar proportions of STIs, meaning that, again, the largest numbers come from the Guayas and Pichincha province, with some scattered numbers here and there throughout the rest. And so the main characteristics of the affected populations include people engaging in high-risk sexual behavior, multiple partners engaging in unprotected sex, men who have sex with men, sex workers, prisoners, transgender people, and also including women and children of infected pregnant women, indigenous people, and rural Ecuadorians. And so some of these populations are, of course, more relevant for other areas of Ecuador, but especially the last few bullet points are the ones that maybe PACH would be more focused on. And so these are just the graphs on showcasing the number of people infected by these different STIs. And so this chart shows only the number of people that were hospitalized. So inpatients, people treated as inpatients, and does not include outpatients. So the total number of infections is, of course, going to be much higher than this. But as we can see, the highest number of inpatients include people with AIDS, syphilis, and hepatitis. And so as for future studies, we recommend that PACH look at these diseases, which I will talk about later. But in general, this study that we performed here is a very broad overview of STIs. And from here on out, anything that I'll present is going to be a very broad overview. And we recommend that PACH use this information for future studies to sort of narrow down the focus of on these certain specific diseases. And so moving on to the next slide. Again, this is also showcases the number of people affected through the Ministry of Health data, but this does include inpatients and outpatients. And so we can see that there's a slight change in what infections are the most prevalent. And so gonorrhea is now the most prevalent, syphilis is up there still, herpes is now up there, and HIV, AIDS, and hepatitis B are still present. And so again, we recommend that PACH continue to look at these specific diseases to look at the relevance to the Chimborazo province and to the people that PACH treats. Okay, moving on. And so some social and cultural norms related to STIs and STDs. In general, a study has found that parents hold a restricted view of sexuality in which cultural values such as conservatism, religious beliefs, and machismo are reflected, and where the societal pressure to maintain tradition seems to create a situation of uncertainty, confusion, and concern. And so what that really means is that there is no really sex education nor conversations about sexuality. What there is, though, is parents telling their children to focus on abstinence and fidelity. And so reasons differ by gender. And so what I mean by that is generally they tell women to abstain because it taints their image, or they tell men to abstain and be fit because it ruins the women's image. But the common ground is to prevent contracting STIs, but that is as far as sex education really goes. With HIV/AIDS in particular, high levels of stigma and discrimination exist. In a survey conducted, 36.9% of respondents aged 15 through 49 said they would not buy fresh vegetables from shopkeepers or vendors if they knew that person had HIV. And 26.8% of the same respondents said they do not think children living with HIV should be able to attend school with children who are HIV negative. And so clearly there still exists an atmosphere of misinformation and fear, especially around HIV and AIDS. Also in general, HIV and AIDS, data about HIV and AIDS will of course be more prevalent due to the global emphasis on these compared to other STIs. And so existing capacities and access to goods and services, rapid tests for HIV exists in Ecuador, and also a national plan for ART, which is the antiretroviral therapy to treat HIV, was implemented in 2003. For other diseases, there is an insufficient and possibly inaccurate diagnostics. For example, one study brought up specifically chlamydia, and if you take a look at the data that I showed you in the chart earlier, it shows that chlamydia's infection numbers are relatively low in Ecuador, and they state that this is unusual, especially for a developing country. And so they attribute this to possibly insufficient and inaccurate tests. There is, unfortunately, again, little data on access to goods and services for other STIs, and some barriers that we encountered were that we weren't able to access some articles that could have potentially had data on this. Again, there is much data on HIV/AIDS that is just shown here, but yeah, for the sake of time, we'll be moving on for now. So coverage and gaps. UNAID had described an ambitious goal described as the 90-90 goal, which is having 90% of people living with HIV to know their positive status, and 90% of those who know their positive status are receiving treatment, and 90% of those receiving treatment have a suppressed viral load. And this goal is to help end the HIV epidemic worldwide. Ecuador's numbers as they stand currently are 80, 72, and 82. And now given that not many countries in the world have met this goal, Ecuador is of course one of them, but their numbers are promising, but they still need to be pushed further. Some common STI cases could be underrepresented and not included because of identification of these conditions depends on referral patterns. Different clinics may use different procedures for diagnosing these diseases. I had already mentioned this case about chlamydia, and just the general difficulty in observing coverage and gaps due to the important lack of information on STIs due to under-registration, no diagnostic methods, and such. So moving forward. So a call to action for PACH and FIBUSPAM on the case of STIs is to, one, study these diseases further and in more detail in a more narrow approach. As I mentioned, this is really just a general overview of the STIs and STDs because they're such a broad topic, and to possibly provide routine testing and treatment, or at least provide the option to give these to people, because a major issue in Ecuador would be the fact that people who are infected with the diseases may not be aware that they are, due to many cases being asymptomatic, and so they don't need to go testing, or they don't want to. And again, as I mentioned earlier, just the fact that there are many barriers to access testing. So the more available testing and treatments there are, the better it will be to help suppress these cases in Ecuador. And another one based on the literature is that parents expressed a wish for the chance to gain more knowledge to enable them to address sex and sexuality with children. So another opportunity for PACH's expansion could be to potentially provide classes or spaces for both children and parents to talk about sex, sexuality, and sexual education, not only in a biological sense, but also in a values sense, as parents had also felt that the sex education in schools was too biological and too little too late. So, and now moving on, I will also be talking about endemic diseases in Ecuador. Okay, so neglected diseases are so named because they are prevalent in parts of the developing world, being neglected in research and development because they really don't affect the parts of the world where a lot of money exists. And although the regions of these diseases can be classified as endemic, we think that it may still warrant looking into in the non-endemic areas, with the assumption that reported cases are again not representative of actual numbers. And so again, due to the broad term of endemic diseases, we will be looking at only a select few based on the literature. And under these, some have been largely controlled through strong governmental programs, but others remain an issue that continue to grow, and we will look at those. And again, the main drivers of the issues is the fact that these are neglected diseases and not really researched upon. So moving on. The geographical extent of affected areas differ by different diseases. And so here we have outlined 6 diseases that we took a look at into the literature. And these affect different areas due to the way that they're transmitted, but the ones that are most relevant to Chimborazo, the province of Chimborazo, would be Chagas, brucellosis, and rabies. And the number of people affected, I apologize, this is a lot of numbers. It is more clearly outlined in the actual reports. And so I will not be going through these numbers. We will be going through in more detail in the next couple of slides. So moving on. So the response to date, as I mentioned, some of these diseases have been controlled. And so these are some of them. Rabies has been largely controlled after a massive and successful vaccination campaign of dogs, leading to over 80% coverage of canines, as well as a public neutering program. Onchocerciasis has also been largely contained through a mass drug administration program that was initiated in 1991, in which coverage of over 85% of the eligible population was consistently achieved for much of the 16-year period of this program. And after this program was ended, a post-treatment surveillance 3 years after stopping treatment confirmed that no active transmission of the parasite Volvulus is present in the endemic area. And brucellosis, the serological controls are performed on a regular basis in groups of high risks, like farms and slaughterhouse workers, because brucellosis is contracted through mostly farm animals. And when an isolate is discovered, they are vaccinated and an infected animal is destroyed. Infected dairy is also removed from the market. However, with brucellosis in particular, it is important to note that treatment medication and length of treatment is highly variable, and thus clinical studies are needed to elucidate the optimum therapeutic approach for this uncommon but life-threatening manifestation. And so all of these responses show that if there is actual work and research and effort put into containing these diseases, that success can happen, but unfortunately, many of them are still so-called neglected. And so moving on. Some excluded groups continue to be basically the entire endemic population, especially because of lack of testing and treatment, and even more so in rural communities who may have to walk longer distances to access resources, despite being more susceptible to such diseases. And that is because they often live near livestock, vectors for certain neglected diseases, as well as more likely to have their water source be a tank in rural areas, and so standing water can also attract many different vectors, such as mosquitoes. And so coverage gaps, there's a clear and significant underreporting of cases, especially for Chagas disease, as pointed out by one of the studies. And so even with a lot of the work that has been done, there is a near 100% blood screening coverage, but all the 15 participating blood banks regularly report seropositive blood donors. And the work that has been done, a total of 12 provinces have not been included in these activities, representing an area larger than the covered provinces. Unfortunately, I was not able to see which of these provinces were not covered. So that could be a potential area for further research. And dengue is unique because this is transmitted through mosquitoes. Now, usually in the case of Chimborazo at their altitude, dengue would not be an issue. However, I would like to point out that due to the effects of climate change, a study in Mexico found that the known elevation range in which dengue is able to exist has actually increased. And so the vector was commonly found up to 1,700 meters in elevation and present but rare from 17 to 2130 meters. Again, this still does not reach the range of Chimborazo at about 2,700 meters, but it would still be something to keep an eye on, at least, especially in the coming years with further climate change. Next. And so a call to action for PACH and FIBUSPAM would be to include more research to identify the needs, immediate needs of testing, diagnosis, and treatment that PACH can address to the populations that they serve. And further research to identify Chagas as a continuing epidemic, especially in the highland regions of Ecuador. Echinococosis is also identified as a growing concern, but due to the unavailability of data specific to Ecuador, we were unable to determine what specific regions are endemic for this disease. And so one recommendation could be for PACH to do further research on where this disease actually affects people in Ecuador. And a final recommendation would be to keep rabies, brucellosis, and dengue under surveillance. Even though that rabies and brucellosis were largely controlled, there could still be future outbreaks, especially rabies through other animals besides dogs, such as bats, and brucellosis because of the high prevalence of farm animals around rural communities. And again, to mention dengue, just to keep an eye on it because of the constant changing effects of climate change.
Okay, so next up, I will be discussing the state of mental health as a whole in Ecuador. So mental health in Ecuador has been driven by a variety of historical factors and cultural, economic, and social determinants. Many groups in Ecuador do not have access to mental health services, including women and children and indigenous populations. Reasons for this include social and cultural norms, and that most of the mental health services offered are not located in rural communities. Additionally, most mental health services lie in the private sector where people cannot afford them. Now, these drivers from historical trauma have had an impact on mental health of the Ecuadorian population. These include colonization, gender-based violence, cultural violence, and racism. Even with these historical drivers, mental health for the Ecuadorian population was not taken seriously until the 1960s to the 1970s, in which different dimensions for what comprises health were taken into account, which for the first time included mental health. Other drivers for the mental health crisis in Ecuador include the high rate of unemployment, number of teen suicides, domestic violence, gender issues, and drug trafficking, which have brought attention to both the government and the general population to the need for mental health services. There's no geographical segmentation when it comes to how mental health affects Ecuadorians, and in general, the most common mental illness is depression, followed by anxiety, stress, and polysubstance misuse. One study conducted in 2021 on Ecuadorians found that 1/3 of the sample population had mental health problems, with females, younger individuals, and students experiencing more severe negative psychological impacts. The authors of this same study found that women have significantly higher levels of depression, anxiety, and stress than males, a similar finding to other studies around the world. And what could account for this disproportionate burden amongst Ecuadorian women are an increase in domestic violence against women during the quarantines due to the COVID-19 pandemic and a higher risk of losing their job and income. So in Ecuador, the initial investments in modern mental health practices began in 2014. However, the mental health budget in this nation only amounts to 1.3% of the general budget for public health. Thus far, interventions in public mental health have been contextualized in different manners. So one includes vindicating healing practices from indigenous groups who have been historically marginalized, and second, including them in modern medicine practices. However, mental health initiatives like these are rare in Ecuador. This can be accounted for by the second intervention because there have been examples to integrate indigenous health practices into available modern mental health services, but These collaborations can occur within a framework of global mental health, which has been criticized for imposing Western concepts and ignoring local influences on well-being. With mental health, the stigma around it remains a huge obstacle in the level of support and treatment that people receive. Another barrier for Ecuadorians, specifically women in particular that I just mentioned, when trying to access mental health services is domestic violence. With domestic violence, in one study, Ecuadorian women spoke about how nearly all of them grew up watching their mother be abused or watched friends, sisters, and neighbors be abused. Domestic violence further affected the health of these Ecuadorian women by inflicting biopsychosocial stress, which can lead to a multitude of health problems, including physical illnesses. Also, a child who witnesses violence, this experience can have a lasting effect on the child's health and well-being. This could be via causing chronic stress and internalizing the message that violence against women is acceptable and an inherent part of an intimate relationship. Most of the services provided for mental health are in the private sector rather than the public sector, but in the public sector, mental health services and resources in Ecuador are organized at 3 tiers and are provided by a mental health community network known as the Red de Salud Mental Comunitaria. So the first tier, tier 1, is inclusive of healthcare centers that offer psychological, general, or intensive care. Tier 2 includes the basic and general hospitals offering emergency attention or outpatient and inpatient treatments through a referral process from Tier 1. And in Tier 3, it includes specialized hospitals and centers for complex cases. Now, to be licensed to provide mental health services in Ecuador, it's not similar to the license process here in the US. Master's level and doctorate degrees in counseling education or counseling psychology are not yet available in Ecuador. However, there are mental health educational programs offered at universities which admit students right after high school. So these particular programs are 5-year programs consisting of 3 years of a study in psychology and 2 years of practice, like in a practicum or an internship. These programs are accredited by the Ecuadorian Ministry of Education, and graduates of these programs are certified to practice with individuals, groups, or families. And graduates of these programs commonly use the title of psicólogo or licenciado en psicología. When it comes to accessing mental health services in Ecuador, various groups are excluded. 40% of Ecuador's total population are individuals living in rural areas who cannot afford professionally counseling services. This is because professional counseling services are available primarily in cities where wealthier populations reside. Additionally, other groups who face serious challenges in accessing healthcare services like mental health are the LGBT and intersex people, people living with HIV/AIDS, and people on the move. Also, the rural population and populations in poverty face challenges because of the limited number of services and human resources for them. Finally, Indigenous and Afro-Ecuadorian peoples show worse health indicators. Specifically with Indigenous communities, access to educational and mental health services is limited. With Indigenous children in particular, 80% of Indigenous children live in poverty and in rural areas, and having scarce resources makes it difficult for Indigenous children to access services far from their communities. Additionally, Indigenous children attend schools that are not equipped to offer mental health services with professionals trained under the Western view of mental health or with mental health professionals who speak Quechua. For PACH and FIBUSPAM, there exist suggestions from the literature in improving interventions for mental health. For example, implementing culturally sensitive clinical interventions and listening to the community to get their feedback on the needs and wants when it comes to potential mental health interventions. Additionally, since the Chimborazo province has a high Indigenous community population, integrating traditional and modern mental health practices would go a long way in improving mental health service delivery for this population. Specifically, PACH and FIBUSPAM could start by creating surveys and getting feedback from the community about if they would like in-unit mental health services, and if there is reception from the community, then working with them to see what kind of mental health services should be offered would be the best way to improve mental health outcomes in the Chimborazo province.
In this final section of the presentation, I'll be addressing the prevalence of cervical cancer and HPV infection in Ecuador. Currently, cervical cancer is the second most common cancer and the third leading cause of death among Ecuadorian women. It is clear that cervical cancer is quite prevalent in Ecuador, despite it being relatively preventable disease. The primary cause of cervical cancer is human papillomavirus infection, otherwise known as HPV. The most common HPV infections that lead to cervical cancer are HPV 16 and HPV 18 strains transmitted through sexual activity. However, cofactors are often required in order for HPV infection to develop into cervical cancer lesions. The most well-studied cofactors include tobacco use, high parity, also known as high fertility, long-term use of hormonal contraceptives, and co-infection with HIV. Other possible cofactors that are being studied include genetics, infection by other viruses and pathogens, and dietary deficiencies. The only geographic areas that were studied during this program were Cuenca, Quito, Guayaquil, Loja, and Manabí. However, it can be assumed that cervical cancer cases occur in all regions of Ecuador based on the fact that HPV vaccination programs are widespread throughout the country. Based on a report released by the HPV Information Center in 2020, there are 1,612 cervical cancer cases annually with 838 deaths. The age range is 15 to 65 years old, but the median age range is about 19 years old. In a study conducted earlier in the year, it was found that less than 5% of mestizo women in their sample size tested positive for cervical cancer lesions. These women also had typically received secondary education as well. The assumption made based on this study is that cervical cancer lesions are more common in indigenous and rural communities due to low HPV vaccination rates and lack of regular screenings. This table is from the HPV Information Center Summary Review published in 2020. Based on this information, we can see that Guayaquil has the highest number of cases of these regions. However, Loja has the highest ratio of cervical cancer cases, but I also wanted to note that obviously there are a lot of regions that were not covered in this report. And so the exact provinces that might have higher cases were not reported. A study with Ecuadorian women participants was not found in relation to cultural and social norms to cervical cancer, but we made some assumptions based on a study conducted in the Peruvian Andes. It is common that those with cervical cancer do not seek treatment until their health has become a serious issue. Some reasons for this include limited education in preventative healthcare, racism faced among indigenous groups in healthcare settings, and lack of healthcare workers being able to speak Quechua. Another reason was many associate a cancer diagnosis with a death sentence, not realizing that cancer diagnosed in the early stages can be treated. We recommend a study with similar parameters to be conducted with an Ecuadorian sample to determine common attitudes towards cervical cancer diagnosis and treatment. In 2014, a nationwide HPV vaccination program was enacted. The program targets 9-year-old girls to be dosed twice on a 6-month schedule. The vaccines are primarily administered via schools or healthcare facilities. There are also cytology screenings, otherwise known as pap smears, available free of charge in healthcare facilities for women aged 35 to 65. The recommended screening frequency currently is 5 years. Though any sexually active woman is subjected to HPV infection that could develop into cervical cancer, those who live in rural or indigenous communities may be at higher risk as screenings and HPV vaccinations are not as common. Inequality still exists between socioeconomic groups, with those from low socioeconomic backgrounds being subjected to racism, low education, and negative feelings towards healthcare. The HPV Information Center reveals that a large proportion of women do not receive regular cervical cancer screenings regardless of socioeconomic status. Many have had a screening at least once in their life, but most do not get screened every 2 to 5 years. This table shows the statistics of coverage for cervical cancer screenings, drawing comparisons between regular versus lifetime. As we can see, the highest coverage percentage is among urban women at 71%, receiving a screening at least once in their life. And the lowest coverage percentage is among rural women at 23%, receiving regular screenings. So as we can see, those living in urban communities are typically able to get screened more frequently than those who are from rural communities. But in general, more women have been screened at least once in their life, but do not seek regular screenings. So based on the information presented, there are a few actions that PACH and FIBUSPAM can take on to tackle the cervical cancer and HPV infection epidemic. The first is to conduct a study of vaccination rates among women not targeted by the National Vaccination Program. The study should additionally look into vaccines available for women between ages 15 and 45 and possible reasons why some are against vaccination. A second action is creating a program that implements regular cervical cancer screenings. As evident, many have access to cervical cancer screenings, but often do not get checked every few years as recommended. It can take several years of cervical cancer lesions to develop after the onset of HPV infection, making regular screenings a necessary step in reducing the amount of cervical cancer cases. Some points of interest could be analyzing inequalities in access to regular screenings among women of different socioeconomic groups and why some women are against regular screenings. A third larger project that could encapsulate other preventable diseases would be working towards better education on preventative healthcare. In addition to teaching about preventative healthcare on Caravana trips, we urge
Did we lose Adrian, I believe? Maybe.
I think so. I think we did. But that was her last point about education and preventative medicine through the use of photonovellas and radio advertisements.
Cool.
Yeah, I guess just for like photonovellas to teach about just in
urge
like
that
a
marketing
visual manner,
strategies.
to teach in a visual manner, like preventative measures like such as cervical screenings, and also radio advertisements or print advertisements in both Spanish and Quechua to reach a wider population. So.
Adrian, are you back? Do you have any?
Yeah, I'm so
Okay.
sorry.
No,
It
it's
looks like
okay.
my internet cut out. Hopefully not too much was missed, but thanks, Cody, for picking up on that. But yeah, I just wanted to segue into Charlotte, who is going to be summarizing the community survey.
Hi, yes, okay, I will just share screen now. Okay, yes, so in the beginning of this process, we all got grouped into teams and we created survey questions surrounding different topics. And we ended up narrowing our scope to just COVID-19 and mental health because of our limited time. Let's see, present. Okay. Can you hear me okay? Sometimes my Wi-Fi is bad. Okay, perfect. Yes, so I just worked on formatting the survey, sending it out, and then collecting the results, analyzing them, and illustrating some of them so you can see them visually. So the first couple of questions that I did were grid questions. So for example, the first one, we asked about the probability of events occurring during the pandemic. So down one column, we had the list of events, and then going across, we had no probability, high probability, and has occurred. And the first couple of questions were formatted in a similar manner. And something that I noticed with this sort of format was that in this format, a lot of times people did not answer them to completion, or they would only pick and choose certain ones in the grid to answer. So that's why I put the total participants as well, so you can get a better idea of how many participants are answering. So I picked out just some interesting points that I found. So 5 out of 16 participants said that there's no possibility that they would get infected by COVID, and 6 out of 23 said that there was no possibility that they could get infected and then transmit it to someone else. And I picked these out just because I thought it was interesting to get insight into the perception of Ecuadorians when it comes to infection and transmission. 10 out of 23 participants said that they had already been infected and then infected someone else. And 11 out of 20 said someone that they know had been infected. And then the last 2, which I found as some of the most striking of answers, was 18 out of 33. So over half of those who answered the question said that they actually had already been to the hospital because they had been infected with COVID. And 6 out of 17 said that they had a friend, family member, or coworker that had already passed away from COVID-19. The next question asked about confidence in sources to give accurate information regarding COVID-19. So for this question, I used a scale and then quantified the choices to calculate what I sort of called an overall confidence score or rating. So no confidence, 0 points, a little bit of confidence, 1, and a lot, 2. So I compiled all of those and made a graphic. And I can point out, as you can see in the confidence rating, any sort of government official or political figure in Ecuador had very low confidence ratings. And again, even when Pooja was talking about vaccination rollout and the lack of transparency between government and the general public, I think this echoes the distrust between the people and government. Another thing to note was that doctors and medical providers by far had the greatest confidence rating. Again, this could be biased because the people taking the survey were people that came to the FIBUSPAM clinic. But again, I think this emphasizes the importance for FIBUSPAM to provide coverage of COVID-19 and COVID-19 services because of the trust that people put into the clinic. And then the last sort of grid question that we had was about actions to prevent the spread of COVID. So for all the different preventative measures, the survey results were overwhelming in saying that the measures were muy efectivo. It's just, like I said, with the grid, the quantity of votes varied, people choosing to answer certain aspects of the grid. So I just compiled that into a little illustration so you could see, obviously using a mask, people thought that that was the most effective measure against COVID. We also put praying in there too, just be interesting to see the religious aspect. So yeah, that was preventative actions. And then the second aspect, we talked about mental health, and all of these questions were multiple choice, and these were much more successful in getting responses. And I forgot to say in the beginning, but we overall got a total number of 56 participants for the survey, and for the mental health section of multiple choice, we had 54, 55, 56 responses for each one. So these ones were a lot more consistent. The first question asking about, do you even believe mental illness like depression, anxiety, etc. Exists or common in your community? Oh, and in parentheses, I put the number of participants if you want to know that. So the majority believe that mental health did exist. And I put the rest as well because I thought it was interesting that 26.8% said that they didn't know if it existed, because I think this points out again the gap of knowledge on mental health awareness and the need for education in recognizing mental illness in communities. The second question, with what frequency do you feel overwhelmed, like you do not have control of your own life? So a third said sometimes, a third said rarely, a fourth said never, and then the minority said a lot of the time and all of the time. And then the final slide has the rest of the questions. So, are you interested in bettering your mental health? And I was happy to see that answer as overwhelmingly yes, at 89.1%. And again, I think this sort of shows that there's room for initiatives for FIBUSPAM to have some sort of mental health initiative or educational program. Again, because like in the COVID-19 question, FIBUSPAM does have trust in it. And I think they could benefit from some educational programs on mental health. Do you enjoy your life? 76.8% said yes. And how has COVID-19 impacted your mental health? As you know, it's pretty intuitive, but the majority said that they felt more worried or sad. 28.6% said not affected. And I found this interesting, so I put it in. 5.4% said they actually felt happier, which was interesting to see. Maybe the pandemic made them grateful for what they have or more aware of the little things in life. Yes, and then just some overall takeaways from making a survey, since the team did talk about before, if you wanted to do a mental health initiative, it could be beneficial to implement surveys about what programming the people of the community would benefit from. So takeaways that I got from making the survey: format of the question, I touched on this before, but multiple choice was much more successful and consistent. The grid questions, people don't like them, they're lengthier, and because of this, it's more difficult to find trends and draw conclusions from them. Also, concerns over anonymity. So right after I sent out the survey, I would monitor it pretty frequently. And in the beginning, there were a lot more questions left blank. And then after talking with Zach, he had me insert a little paragraph that talked about your results are confidential, your participation is completely anonymous. And I noticed that adding that preface to the survey really helped increase the number of complete responses in the survey. And obviously time constraints, more responses, more time would strengthen the conclusions and reliability of the survey. But it was very interesting, and I'm glad we got to do this and see some notable statistics. So thank you.
Well, thank you very much, you guys. This was really impressive. And, I'd like to restate that, these participants in this project team that have never been to Ecuador, have really had no familiarity with Ecuador. And also just the depth and intensity of these topics were probably very new to you guys. And I commend you for the amount of research that you guys did, not only in gathering the research, but analyzing and synthesizing it. And it's very, very impressive. And we're very grateful for this information. And please feel free to share, actually, if you guys, did you guys find anything that, personally struck you through this this process, or anything interesting? I don't know if.
You mean, Zach, from our point of view?
Oh, well, I mean, there's two. I mean, like perhaps if anything personally, like that they actually learned, that just struck them.
We'll let them go first.
Yeah. But
I think kind of for me, like when trying to put this desk review together, because like obviously this is the presentation, but the actual deliverable of the desk review that we created was like over 30 pages. Like we were just surprised of like how much research we were able to find. And I think like for us, the biggest struggle in the beginning was like, how do we choose what to talk about? Like there's so much, because like the prompt was just like conduct a general health like review of like the health status in general, and I was like, that could include so many different things. So I think like narrowing it down was like really hard for us, but I think like as we got into our like specific sections, like it helped us like kind of like dive more into that issue and things like that.
I see Sarah has her hand up there.
I actually have a question for the team, if that's okay. I'm really curious about the number of sources that you had in Spanish versus English. Was it hard to identify studies? Were you looking at resources in Spanish, English, or a combination thereof?
for me specifically, it was more English than in Spanish. The Spanish resources that were available, I actually tended to find that the translations were pretty poor. So thankfully that there was the Spanish available that I was able to read to like sort of get a better understanding of what they're trying to say. And then at times I also felt that the tables were also more ambiguous as to like what they were actually showing. But it was still definitely very, very useful to be able to read because so one of the resources that I found that was in Spanish that had poor translation was actually specifically about the Chimborazo province. And so I got a little bit of that data that was more relevant to us. So I found that to be really interesting too, just what is available out there.
Great.
I also love the recommendations that you added at the end of each section. And just so you know, as interns, this presentation will continue to be used. I think that a lot of the data that you presented could not only help orient teams. For example, if we have a team coming down to do cervical cancer screening, the information that you presented is super helpful. But also this information could be easily used as we write grants and proposals and prepare projects in accordance with your recommendations. So thank you so much for that. And again, as I said yesterday, I am just super shocked at how much information you have gathered and gained and how you have synthesized it without ever stepping foot in Ecuador. This is just so efficient, and I congratulate all of you.
Yeah, and I'll second that once again. And also, it was very, very helpful to have our team at FIBUSPAM to provide feedback for us, and just and also Dr. Rachel Hennish, like her presentation and her sharing on cervical cancer and epidemiology in Ecuador really helped give a little bit of a background. And this is really just the beginning for these type of projects, and you guys did a commendable job on this. Well, perhaps.
Paul, do you have any comments? It looks like you want to say something, maybe.
Do I have any comments? Do I have a page full of comments? No, I want to commend everybody. I'm amazed that you put your finger on so many of the really difficult problems down there without having been there. And I hope you get the chance to actually go there, because it's one thing to know they exist, it's another thing to see it in front of you. And so I'm particularly impressed by all of the issues that you hit in terms of mental health, particularly with women, because I've been going down there for 20 years now, and I still think that the problem is bigger than I think it is. It's hard to find a woman there that has not been abused in some fashion, including whether it's just physical abuse or sexual abuse or interfamilial sexual abuse, which these things are big, big problems, and tackling them is daunting. I tried to make you rightly mentioned the use of radio and the use of videos, to teach people about things, right? So I had this great idea that I was going to use our caravanas and I was going to use the clinic. We bought TVs for the clinic, and I made a great video, I thought, in Spanish of the need for vasectomies and family planning. And I can tell you with complete certainty that the men don't watch it. They pay no attention whatsoever. And that's when I realized how big these problems, how deeply ingrained these problems are in these communities. The men do not want to hear about it. This is not my job. This is my wife's job. If I want to have 12 kids, I guess that's just, my business. And so anyway, I don't know how you crack the shell on some of these problems, but I will leave that up to you folks. And I hope very much that you get the chance to come down to the clinic sometime and actually see these things up close. So congratulations on your great work. That was super.
Yep. Well, we'll take this opportunity to wrap everything up. Thank you guys very much. And we will be taking this video and sharing it with our PACH and FIBUSPAM family next week, and along with all the other videos. And we look forward to more feedback, and we look forward to you guys engaging with our projects in the future.
Thank you all for
Thank you so
attending and for your
much.
feedback.
Yeah,
Thank you.
Thank you.
Thank you.
Thank you.